Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to discuss supplemental oxygen therapy. When should we start giving oxygen to a patient? Before talking about indications for oxygen therapy, I would like to explain some bases of oxygen delivery and oxygen content, which are quite important to understand the reasons why a patient could be hypoxic. We can calculate the oxygen delivery in arterial blood by cardiac output times oxygen content of arterial blood. The formula to calculate the oxygen content of arterial blood is this. Here we can see the oxygen delivery of a patient mainly depends on factors such as arterial oxygen saturation, arterial oxygen pressure, cardiac output, and hemoglobin. In case you're curious where these numbers come from, 1.34 is the coefficient of hemoglobin oxygen binding capacity, which means that 1 gram of hemoglobin can carry 1.34 ml of oxygen. 0.023 is used to estimate the proportion of oxygen dissolved in 100 ml of plasma per kilopascal of partial pressure. Now, it's a bit clearer when we should consider giving a patient supplemental oxygen. Obviously, during emergency situations like cardiac or respiratory arrest, when oxygen saturation drops below 90% or PaO2 below 8 kilopascal, if a patient is in shock with systolic blood pressure below 100, could be due to, for example, cardiogenic shock, sepsis, and hypovolemia. When a patient is severely anemic, like hemoglobin is less than 70, we could enhance the arterial oxygen content of the patient by providing oxygen therapy in addition to blood transfusion. It is not mandatory, but we should consider oxygenating a patient with supplemental oxygen if there is respiratory distress with severe metabolic acidosis, especially lactic acidosis, to reduce the work of breathing and also an anaerobic metabolism of the patient. The major benefit of oxygen therapy is to save organ functions by optimizing cellular metabolism. However, we should bear in mind that there are risks associated with it. I would like to draw a diagram here. Probably it will be a bit more understandable. If we give a lot more oxygen to a patient than necessary, it could inhibit hypoxic ventilatory drive, resulting in hypoventilation and retention of CO2. It could be particularly dangerous in patients with type 2 respiratory failure in COPD, for instance. Hypercapnia could be due to washout of CO2 from hemoglobin by hyperoxia as well. It is called halting effect. Not only that, too much oxygen could also displace nitrogen from alveoli, causing microatelectasis in poorly ventilated alveoli in diseased lungs, which is known as absorption collapse. Moreover, prolonged high level of oxygen therapy could directly damage the alveolar membrane by oxidative stress as well as traumatic lung injury, especially in patients with positive pressure mechanical ventilation. Hypoxia is a potent pulmonary vasodilator, so high level of FiO2 could diminish that effect, leading to increased death space and ventilation perfusion mismatch due to reduced blood flow in well-ventilated alveoli. As pulmonary vasoconstriction in lungs, hyperoxia could precipitate coronary and cerebral vasospasm. Therefore, it may worsen outcome in post-cardiac arrest or myocardial infarct patients, so we should avoid it. How can we monitor critically ill patients on oxygen therapy? We can do non-invasive monitoring like SpO2 and invasive monitoring like arterial blood gas to check PaO2, lactate, and HB. In patients with cardiogenic shock, we can consider monitoring cardiac output by pulse control cardiac output monitoring, PICO for example. We should also assess patients clinically by observing respiratory rate and work of breathing. Generally, the target oxygen saturation is 94 to 98% and PaO2 is above 8 kPa in ICU patients unless they have chronic type 2 respiratory failure such as COPD, cystic fibrosis, obesity-related hypoventilation syndrome, neuromuscular or chest wall disorders. In those scenarios, we should keep the SAS between 88 to 92%. Here, I would like to discuss why we could tolerate SaO2 above 90% and PaO2 above 8 kPa. Normally, the difference between FiO2 and PaO2 is about 10, which means when we breathe room air, that is FiO2 21%, our PaO2 will be expected to be around 11 kPa. Hence, if a patient is on 60% of FiO2 and SaO2 is around 94%, we would expect PaO2 to be around 50 kPa. However, PaO2 will probably be only around 9 kPa with that high amount of FiO2 in severe lung diseases. So you might think that the target PaO2 8 kPa will be too low. If we have a look at the oxygen hemoglobin dissociation curve here, until PaO2 of 8 kPa, oxygen saturation would not fall fast from about 90% for a small change in PaO2. Below 8 kPa, we can see SaO2 will start to plummet with some minor changes in PaO2. Therefore, in critically unwell patients requiring a lot of oxygen, we could tolerate SaO2 above 90% and PaO2 above 8 kPa, which we call it permissive hypoxemia. However, we tend to keep PaO2 above 13 kPa in patients with traumatic brain injury as a neuroprotective measure. Now, I would like to discuss the ways to provide supplemental oxygen to a patient. We need to bear in mind that FiO2 delivered to the patient depends on oxygen flow rate, patient's inspiratory flow, respiratory rate, and the amount of air entrained into the device we're using. I'll give you an example here. The general rule of thumb is that each additional 1 liter per minute of oxygen flow increases FiO2 by around 4%. So normally, if oxygen is delivered at the flow of 4 liter per minute, FiO2 delivered is supposed to be around 36% in a patient with normal respiratory rate. However, if the patient is tachypnic with high inspiratory flow, then ordinary room air will be entrained during inspiration. Therefore, the true FiO2 delivered to the patient will be a lot lower than we imagine. To overcome this entrainment problem, we can use reservoir bag in non-rebreather mask to give the highest possible level of FiO2. The oxygen flow up to 6 liters per minute, which is FiO2 up to 45%, we can utilize nasal cannula or nasal specs. Nasal cannula uses the dead space of nasopharynx as oxygen reservoir. Patients could tolerate it more, especially when they're eating, drinking, or speaking. The downsides are it could cause nasal drying and itchiness. It may not work very well in mouth breathers, and the delivered FiO2 may not be accurate, as I mentioned above. Simple face mask, Hassan mask, can be used to provide the oxygen flow between 5 to 10 liters per minute, FiO2 between 45 to 60%. It has an advantage over nasal cannula when higher flow and FiO2 is needed. Nevertheless, it could be quite uncomfortable, especially in patients who are claustrophobic. Also, lower flow rates of oxygen could cause exhaled carbon dioxide build up within the mask, so we should avoid it in type 2 respiratory failure. Again, like nasal cannula, it depends on the flow rate and breathing pattern of the patient. In patients with chronic type 2 respiratory failure, we can use venturi mask since it could deliver the estimate of FiO2 as we desire. Hence, it's very helpful to give controlled oxygen in COPD patients. There are slits found on the side of the color-coded valves, which allow air to be entrained. The size and degree of entrainment varies with different masks. 24% in blue, 28% in white, 35% in yellow, 40% in red, and 60% in green. In emergency or trauma patients, non-rebreather mask with reservoir bag should be used to give high-flow oxygen with 10 to 15 liters per minute, which is FiO2 around 60 to 90%. The bag acts as reservoir of 100% oxygen, overcoming the entrainment problem. If the patient is still hypoxic on 15 liters per minute of oxygen with non-rebreather, we should consider oxygenating the patient in a more efficient way, which is by using humidified high-flow nasal cannula or non-invasive ventilation, which I will discuss in other videos. This is a bit summary of supplemental oxygen therapy in intensive care unit. Hope this video is useful to you. If it is, please share it with your friends and colleagues. I'll see you in the next video. Take care.